So hello again, Designed to Connect listeners. We are so happy again today with another episode. This is our last episode of this season, the Care series. And yeah, we are really excited because we are going to talk about one of my favorite topics in the world, no exaggeration. Yeah, it is. It is. Okay, I'm going to take this part off, but yeah. So we are going to talk about health and behavior and how our health is kind of impacted by the way that we design spaces and we design our urban space, our architectural spaces, and yeah, these topics, how they are related. And I'm super excited about this topic because during when I was studying architecture, no one ever told me that what I design can impact people's behavior and how they feel both mentally and physically. And then the moment that this door opened in my life, I was like, oh my God, just bring it in because it was cool. It's interesting. Today we have an expert about these issues with us, and we are super excited to dive in. So I'm going to stop talking. So yeah, Khadija, who do we have with us today?
Yeah, so today with us we have Giorgia, and she's an assistant professor based in the Faculty of Epidemiology and Population Health at the London School of Hygiene and Tropical Medicine. She has also been consulting for the WHO IPC unit and Africa CDC, and I think the reason why she's here because she focuses on behavioral change and evaluation design. And the two areas of her research are improving infection prevention in healthcare environment and design better intervention to improve the uptake of climate change adaptation and mitigation intervention. And another reason why she's here is because she's mainly focused on health of young women, mothers, and newborns. So, how we could not finish our series in a better way.
Yeah, it's perfect. We started in this.
Yes, we started in the realm of women and mothers, and we are finishing it in it.
It's a full circle.
Yes. Welcome, Giorgia.
Thank you so much. It's a pleasure to be here with you guys. Thanks a lot.
Thank you, and thank you for your time. And we have to say that we know each other. We are from the same hometown. And we've met years ago, thanks to another friend. And I've almost came with you to Zanzibar at some stage. Unfortunately, I couldn't because you were working on a really interesting project in a delivery room. So how to get basically a participatory design and participatory process there. And I think maybe the first theme we want to delve into with you, it's really how does, in your opinion, in your experience, of course, the built environment impact people health? Because as Arzu was saying, it's something that usually they don't teach you in the architecture environment is how you really impact by drawing a line and then build it in the real world. So how do you feel about that? What have you studied and see?
Such a small question, by the way.
Such a small question, yeah.
Well, I think it's obviously a complex question, and I think it really depends on the health issue that you have at hand. But I think increasingly when we think about chronic diseases, the built environment and urban design is becoming increasingly important. And what do I mean by that? Essentially, that we, in the type of environment we live in, kind of lead us to walk more or less, take public transport more or less, eat in a certain way. And I think one of the seminal reports that I can think of is actually the Foresight report in 2007 from the UK government, which was actually the first multi-ministry and multidisciplinary report around obesity. And this was 2007 exactly. And it kind of tries to map, if you have a look, if you actually Google Foresight Report 2007, there is a beautiful map about all the determinants of obesity. And it's enormous, obviously, because we're going all the way from supermarkets design to, urban deserts and everything in between. And essentially, it was the first kind of attempt from a government to try and realize that actually this is very much a cross-disciplinary issue. And only by making sure that different types of ministries in the government work together, they will be able to tackle that. Yeah. And I think many of the issues that this report kind of comes up with is not just to do with obesity, it's also to do with cardiovascular disease. We all know physical activity is essential actually in our day-to-day life to make sure that we are healthy in the long run. And now thinking, on the other hand, an issue around decarbonization and how we switch to sort of modes of transport that are healthier for the environment. There is increasingly more and more studies looking at the health co-benefits of these choices. If you actually end up taking public transport, if you can take public transport, because a lot of it is opportunity and access, you not only have good impact on reduction of CO2 emission, but you also have an impact on your health. If you are in a city where more people walk and do a minimal amount of activity every day, it's a huge gain for the population as a whole. So personally, I think actually it has a huge impact. Probably the simplest example that I can think of that I think we all can relate to is the smoking campaign. I think you probably remember the world before 2005 when smoking was allowed in public spaces and indoor, right? And I mean, at the beginning, there was a huge resistance to that, and then it completely turned around. And now, you would never think of someone smoking in an airplane, smoking in a train, smoking in a restaurant where you're eating. And that's, to me, like a very, very important example of how the built environment, I would call it built environment plus, right? Because we're still talking here about social behaviors, things that you do together. So here, like by then the smoking campaign had already like 20 years of public health funding behind it. It wasn't the first attempt to really tackle smoking cessation, but it was definitely the most efficient. Why? Because they really tackled the social environment of smoking. And it took a while to get there, but it was a game changer. And I think that's just one of the key examples when you think about built environment and health.
And we have so many things to say.
Sorry, I just wanted to sort of give you a bit of a...
No, it's really a great introduction. And because I was also, I think, listening to some podcasts there, and they were mentioning the Eat Smoke campaign. And one of the main resistance we always have to change, also in my practice, is we cannot change this because we are going to lose a lot of money, a lot of jobs. And it's always like, how do you shift the point of view from losing jobs now and versus losing actual people in person to it. And it's always so hard to get over this challenge. And sometimes you need really to, sometimes you just need to make it fun. Because one of the things that came up to my mind when you suggested this topic was this, it's some couple of video they did, they call it the fun theory. So one of the example was people, instead of taking the escalator, they were taking this musical stair, but because it was fun. So sometimes you don't really need, I feel, to tell to people what to do, but to find, maybe an easier way or an incentive to make people change their behavior. I mean, easier said than done, but
yeah, definitely. And yeah, as you were mentioning the health impacts, I was also thinking, because the walkability example, we heard about it and how it impacts physical and mental health, and like in the, let's say, the architecture urban design community is very famous, but the cigarette campaign, I didn't know about it, and I'm curious to know, like, this change of norm, did it in general decrease the number of smokers? Like, did it impact also the people who were smoking and decrease like their behaviors to smoke less in general? Or is the impact mostly on the people who are next to smokers in a closed space, and like smoking can impact their health?
No, it's actually on the targeted smokers. Okay. Yeah, that was a really big gain. I mean, I don't have the stats with me, so I'm I'm not going to try and make them up, but there is a substantial reduction. It wasn't just that, by the way. You know, we're talking about public health campaigns that span a wide range of behaviors. So obviously, if you had that type of, because it's a coercion system, right? They put a ban, right? So it was a coercive type of measure. So if you just put that without anything else, probably wouldn't have been as successful. But there was a huge information campaign. In the UK, for example, you had smoking cessation points where you could get information, patches. And so it was together with, but I think before then we really underestimated how much the social environment was driving the behavior. And I think that was a really like beautiful, you know, from a behavior change design type of mentality, it was a beautiful proof that that was a big driver, because a lot of it was social smoking, accompanied perhaps also by drinking. And so I think disassociating the two things made it less compelling for people to do it. And of course, it's not that you ended up going to zero. You know, some people persisted in smoking, but you're just giving less opportunities for people to do it. Yeah. But also, Khadija, I did like your point about triggers. And I mean, it's something we call also making something salient. So often in behavior change especially if it's something new, a new habit, you want people to latch onto it to begin with, right? Then it's different than to make something habitual. But at first, you need to give them a good reason or a fun reason. Depending on the behavior and the drivers of the behavior, you kind of choose the right way of getting people to even try for the first time. Yeah, because this is a big hurdle. Trying something for the first time. Then something else is about maintaining behavior. You might have different techniques for maintaining behavior, but making something salient, you know, and giving people the opportunity to try something for the first time really opens up something like an opportunity to then make something habitual and do behavior maintenance. And again, as you said, like it could be something fun. In other contexts, there might be something to do. Like I often work with health workers, and a big thing there is making sure that they can save time. So if you can convince them that the new strategy is going to save them time, they're more likely to give it a shot to begin with. So depending on what it is, you end up like kind of latching on a motivation that you think they might get them to try for the first time and see that it's feasible, it's doable, it's not a big thing. And then you can also work on other strategies that you think about behavior maintenance in the long run. So I agree with your point about triggering and making sure someone gets to it in the first place.
Okay, so moving on to the first point that Khadija was making about like participatory processes and what Khadija knows you from, and you were supposed to kind of collaborate on that, and kind of going into the architectural, let's say, element from urban design. I wanted to ask you about the design of the healthcare facilities and how could participatory processes kind of look in those facilities when we are talking about, you know, patients and healthcare professionals and then designers. How do we bring these different people together, and how do you really get the needs of each of them and put it together and create, you know, something that works for everyone?
Yeah, no, it's a very good question. I mean, I think first of all, there needs to be buy-in from the healthcare institution, which could be a different level. It could be like a clinic, a hospital, a health system. But unless you have buy-in from the parties, it's really hard to do, essentially. So I think the first step is to convince people, however you can, to motivate them that it's a good way to go about it, the participatory process. And some people think it's trivial, but it's not, because if you don't have the buy-in of very busy health workers, especially, you might not be able to pursue it as you wanted. So definitely the buy-in is a big thing. I mean, obviously there is logistic stuff like dedicated personnel, facilitators who know what they're doing, and resources, the right resources, both in terms of time, but also financial resources. And I think in thinking about specifically the healthcare environment, one thing to always watch out everywhere in the world, with different degrees, but essentially everywhere in the world, is the hierarchical system. It's a fundamentally hierarchical place. everywhere, in the UK, in Italy, in Tanzania, in Brazil, in Cambodia, everywhere I worked, I've never found a hospital that runs in a non-hierarchical way.
Okay.
Maybe, in 100 years, things will be different. But as it is now, you're dealing with a hierarchical structures. There are people that count more and there are people that count less. And you can't just be blind to that. You have to take that in consideration. So there are places where you can work across, for example, cadres of health professionals. You can put cleaners together with nurses, together with doctors. There are some places you can't.
Okay.
And you just have to figure it out based on the context. Actually, contextualization of these participatory processes is fundamental. You have to understand what the local norms are. If these people are willing to speak together, there is also the gender element. Can you put women healthcare professionals and male health professionals together? And I think that's a very important dimension, just understanding what your context looks like. Sometimes it essentially means that you have to do things separately for each cadre. So patients would come differently from doctors would come differently from cleaners. Some places you can bring people together, and that's fantastic, but it's not necessarily a given that you can do that. This doesn't mean that the process has to be any less good just because you cannot bring people together. I think sometimes you get to really, really good outcomes even if you speak to people separately, as long as they share the same aims, goals, and they might be motivated by different things. Perhaps the healthcare director is motivated by saving some money, and perhaps the patient is motivated by having a better health, but they bind to the goals of that specific activity. One of the experiences that I was involved in that Khadija kind of mentioned at the beginning was sort of thinking about the maternity ward in Zanzibar. The Minister of Health wanted to sort of attract women to come more to give birth in the healthcare environment. But there were some obvious issues related to hygiene and infection prevention and control, which we kind of looked into. And I think a really important thing linking that with the built environment was that we kind of looked at behavior in space, how the health workers were interacting with patients and how they're interacting within the space allocated to them. And I think that was a really, really important thing. I mean, one thing that we used is called walkthrough. You walk through the facility, understand where people do things associated with a specific location. We also use some methods called time motion methods, where we literally observe people's behavior. It can be written down or computerized. And again, it's linked to the people in that space, but also the location of things, So for example, it's often, unfortunately, true that delivery wards where people actually deliver babies, there can be cluttered places in low resource settings. So you need to think, how do you facilitate that workflow? Otherwise it can be quite messy. It can be very time consuming for health workers to do their work. And at the end, we kind of piloted this sort of participatory method where we actually got the cleaners and health workers involved in assisting delivery to think about their space and literally map out how they walk after we observe them walking around doing procedure, making them think, with big pieces of papers and pens, how they walk around, how they understand their space. And they realized through this process how inefficient their workflow was. And so there was then an intrinsic motivation for them to think about changes. And guiding them through this process helped them thinking, okay, maybe if we put things there, that will be easier. That sets of behaviors. There are some behaviors during a delivery which you do repeatedly, like hand hygiene. For example, if you have to do something 50 times in a span of 4 hours, you want to make sure that as efficient as possible. It's a bit like, I mean, if you think about it, it's not fundamentally different than how we get ready in the morning, right? If you have your clothes in one place and you're going to find them there, if they're going to be clean, if you know where breakfast is, it's going to take you much less time than if you're trying to walk into a house you've never been and trying to find things for the first time. So making sure I guess it relates more to the interior designing part, how in terms of how you move in a certain space. But it was a fantastic experience. Unfortunately, at that point, we couldn't really get the mothers involved, but it's definitely something that other organizations have demonstrated how well that could work. For example, Mass Design, they're based in the US, they do a really good job at including women's voices into redesign of delivery settings. Unfortunately, we didn't have the resources to do that in that particular study. But I think it's really important also the patient perspective into that kind of work. In some places it's easier to do than others. Again, depends on resources and willingness to change, but it's a really important aspect. Not sure if it answers your question.
It does.
A little bit.
Perfectly.
Yeah. And I think it's key, as you were saying, that it doesn't, even if you cannot have everyone in the same at the same time in the same room, it doesn't mean that your process it's less efficient. And I feel sometimes we are, you get to community process and already they say community, you're like, who is the community we are talking about? And it's like, we want to involve everybody. And you're like, that's impossible. You cannot involve everybody. And because, as you were saying, even the norms are different, the language is different. I mean, sometimes doctors, I'm sorry, doctors, are not really able probably to have a language that a patient can understand. So it's really key, sometimes to get one-to-ones with different groups so that you can adapt even the language and the tools to, to what the person can understand. Because if not, it just doesn't make sense. But, yeah.
Yeah, and moving
Moving again.
today we are going on waves because we have so many questions, but moving from like the design of the space itself to our behavior and like how clean we are as human beings, we wanted to ask you if design can impact our hygiene behaviors, and how could that work? Like if there are certain examples of the way that we design that can lead us to be more clean. Yeah.
Well, yeah, I guess touching a little bit of what I started saying earlier, I think there are some environments where hygiene is even more important, like a healthcare environment, where the guidelines suggest that you need to do it so frequently. So making sure that the health workers have it as easy as they can. Like another pilot we did somewhere else was actually giving health workers personal bottles of hand rub, because often hand bottles are linked to the bed or the wall, but it means you're going somewhere, right? So why not just like we actually literally gave like a necklace with the hand rub bottle to someone, so they had it right there when they needed it. So actually strategically locating hand rub bottle either to the person or to strategic places does seem to help. There are studies that prove that strategically locating these things helps a huge amounts with increasing compliance. So I think in general, for things that are, for behaviors that are habitual and you have to do many times, you'll never have 100%. You'll never reach 100%. That's just basically impossible. But what you can aspire to is to make it as easy as possible to do that behavior, as convenient. You don't have to think about it. Literally, and you have to make it salient. You have to make sure that people are reminded of it. So through the environment or through messaging, but you have to sort of trigger them somehow to remind them, because it's something that you do so many times, you might forget it easily. And so I think a bit like with COVID, right? During COVID, we were used to seeing hand rub all over the place.
Yeah.
And it wasn't, but again, it's environment plus, because if in the absence of a pandemic, someone just started to put hand rub bottles around, you wouldn't have noticed them. So it was a combination of information campaigns on what the hand rub is useful for, in a context of risk, where you have an intrinsic motivation to want to be healthy for you and people who you care about, combined with strategically located access to what you need to perform the behavior intended. So I think it's almost never just one thing. I mean, outside of hand hygiene, I can think how smart supermarkets are. They always put the sweet things next to the counter, right? When you start, actually, like scanning your shopping and then buying it. And why is that? Because you're waiting for a couple of minutes, you can look around, and they trigger one of the things that everyone loves, which is sugar.
Yep.
And that's really, it's really good behavior design, behavior change design.
Yes, it is.
So in that way, similar. So of course there is no one size fit all, but you can do a lot in the sphere of hygiene to kind of make it easier for people to do what they have to do. But again, I think, for example, COVID is a really clear example of how it wasn't just the strategically placed hand rub bottle, it was also the shift in norms, like how risky the environment was, and that people were motivated in a certain way. And I think also we looked in the sphere of hygiene, the pandemic also made us think not just about doing something, but also not doing something, avoiding touching, avoiding coming into someone's personal space, hugging, kissing. And I think social norms tend to be really persistent in society, but it's also really amazing to see how quickly we can shift. Like a handstand that you've been doing since you are 3-4 years old, you're able to change it in a week because you had the right drivers to do it. So I think we're also very flexible, a really flexible species. We want to survive. So we are really good at changing in the right circumstances. So I think it's something to think about when you think about behavior change in general.
Yeah. And also, I was thinking, because one of the things that happened when we were in lockdown, we kept on working. I was still in Belfast, but we were doing, of course, things online, and everybody was talking about how they were just going to not ever again taking the car, just walking around, and it's crazy how much it takes to change the norms, but then to go back to what it was before. And as you were saying, how do you keep those good habits is really key, because it takes just this to change your habit, but then in the long run it's easy to fall back. And if we were as smart as supermarket as as shops, which they have so many, they have so many strategies they use to sell us things. So sometimes I'm like, why we are not able to use the same strategy when it comes to our health and to our citizens' health and to our community health, because we could easily do the same things, but don't really do that. But so they got back to their cars. That's the
Yeah, exactly. And I think that's to me why I'm particularly interested in sort of this idea of exploiting social norms for behavior change, because I think a lot of often part of the reason why we do things is because other people do it. For example, we come from a hometown where me and Khadija, you could literally walk everywhere. Like if you need to go somewhere, you have to but as soon as I got there, I was living there for a year recently, I bought a car because everybody has a car, and public transport is not particularly good. I do have 2 kids, so you can have all the excuses of the world, but it doesn't really matter. Bottom line is that I never owned a car in my life in other big cities where I lived, and I would use transport everywhere. But everybody else had a car, and it's convenient. And why don't you have a car? It's so easy. And and it's sort of, again, of course it wasn't the only reason why I bought a car. There were lots of other reasons, but it was just absolutely striking. And most people have 2 cars, and you're like, why? I don't know. And it's just, and I think it's just fascinating how we're just so driven by what others do, even implicitly. We don't even realize it. And that's in social norm theory, we kind of divide between what others do, which sometimes is called a descriptive norm, and what you think other people should do, which is more an injunctive sort of normative expectation. And I think it's a very important driver of many of the things we do on a daily basis. And so I think if we could shift that, especially in a context, for example, of climate mitigation. Often we think it's a bit like a drop in the ocean, right? Oh, we're the only one recycling so well, or we're the only one who doesn't bother flying to go on holiday, so I spend like 2 days on a train. If we knew that there were like enough other people doing it, we wouldn't feel so lonely, and enough drops in the ocean do make a good pond.
Yeah.
So even if your action has a small impact on CO2 reduction, together with many small other action actually makes a huge difference. So I think bridging that gap between what you do and knowing what others do, sharing a same sort of goal, is a really powerful behavior change technique. We just have to exploit it better. Yeah.
Yeah, and I mean, keep it on talking about challenges.
Hmm.
Yeah, for sure, one is what's the trigger to change the behavior? I mean, for sure, you'll
Yeah.
tell me. And then how do you keep that behavior going? But are there, are there other challenges when it gets to, change people behavior? Yeah, probably we can talk still about healthcare facilities.
Yeah. Yeah. So I think it really depends on the behavior and the context you're operating
Okay.
in. So again, my point about
Yeah.
contextualizing. You really need to understand why people do what they do, where they do it. And often there is not enough funding in research or implementation projects to do that formative phase at the beginning. You really need to understand what motivates people. Obviously, um, there are contexts where, for example, if you're the government, you can use quite radical policies. So, for example, during COVID, lots of things were pretty much
That.
top down, no questions asked. This is how we're going to proceed. And the consequences for not complying to the behavior are quite high. You might get a fine, you would be put in jail. So, do you have a choice there? No, you comply because you don't want to go to jail, you don't want to pay a fine. So, there are some things that are in the power of like government that can be done. I'm not advocating for the use of coercion here, by the way. I'm just trying to explain that there are some challenges, some challenges in behavior change can be more cohesively be coordinated by the government. So, for example, in the UK, I don't know, they did this thing where they reduced amount of salt in bread legally every year in such a subtle way people didn't even realize. But that has a huge contribution to cardiovascular disease, right? So, and it's very interesting. Nobody noticed, but it was a top-down approach. No, nobody complained, and it was a policy that just went in and silently progressed and had impact. And then again, there are, obviously, I think ideally for larger scale uptake in the capitalist society that we live in, if you could have the buy-in of someone that gains from this, you'll go a long way. So if there is someone that can profit out of this, unfortunately, you do go a long way. So the reason why supermarkets are so good is because they want to make more money. And, it sounds basic, but lots of people are driven by that. Um, um, so I think if we had, the same resources that like a big multinational corporation has, would be very different. So a lot of times you're just dealing with lack of resources for something. Yeah, and unfortunately, everything else is really down to, aside from resources, is really try to understand what motivates people. So in the absence of these big players, if you're working with small scale, is to try and how can I get that group of people to kind of come my way? Like, how do I motivate them? What are they motivated by? And that does change depending on the behavior, the local culture and so on. Yeah. Sorry, I don't have there is no like one answer to this, but
It's okay. We never do questions that have one
An
answer.
answer or an answer.
Or an answer.
yeah, or one answer. Yeah.
Yeah, in general. Yeah, as you were saying, but I mean, as you were talking, it
Yeah.
makes me a bit depressed that sadly in our like capitalist society, somehow the unhealthier we are, the better it is for different corporations like to gain money. And so if you say that in a lot of cases the top-down approaches could be more useful, I don't know how can we move forward with improving our health without changing the system that is capitalistic and it's based on consumption. And so it's very hard, and I think they need to go hand in hand together, that the more that we become aware of our health and what impacts our health, and like researchers work on that, the more also we question like the bigger system. Because until that capitalistic system is there, even though we have a lot of knowledge and even though different countries take some little steps, at the end of the day that's what is driving the society. And it's, I don't know, it becomes really hard to to I don't know, move forward and have healthy societies. And but sorry, sad side note.
But on the other hand, I completely agree with you. On the other hand, I mean, especially in some contexts in the world, like let's say the ones we live in Europe, I mean, we are much healthier than we've ever been. We live longer, and arguably we live better. We have more access to food, more access to healthcare. So I think sometimes it's also easy to forget how much things have improved in the last 100 years or 150 years. There is this website called Gapminder, which kind of shows you sort of the Hans Rosling was a very inspiring speaker. I saw him a couple of times here in London, and he would always argue for this kind of more positive way of looking at progress. And we've done a lot of strides in maternal health, in neonatal health, and I think sometimes is really important to remember how much we've achieved. I think it's also really nice that our nature kind of always wants us to do better. And I think we should consistently do better. There's a lot of things that we can improve, especially. I think one of the issues that we're facing now is equitability in sort of outcomes, that I think some of the things are kind of diverging. And I think there are too many opportunities to be healthy for someone with money than someone without. And that's where I think that our biggest challenge is, giving everybody the same opportunities to be healthy. Why is fruits and vegetables so expensive? That's, why are cereals or high sugar yeah, exactly, or crisps so cheap? There are some things that really could be game changers if they were coordinated better. Of course, there are lobbies, there are lobbies of these companies, but I think there's a lot that can be done with relatively circumscriptive policies, not particularly big changes in society or
Something that came up to mind is I think it's the whole UK probably have on the food the label, and also in France on the quality of the food. So I think it's green. Is it green, yellow, and it's like the
orange,
the traffic light system. And I remember we tried like a couple of times to have it in Italy, and everybody was freaking out. I mean, not everybody, a part of the population was freaking out because they did not want it on wine. And you're like, okay, it's how do you really understand who has who are the lobby in your country? And it was one of the reasons why, it did not move forward.
Oh my God. Oh, I didn't know. Okay.
Yeah, every couple of years it comes in the. I don't know.
Push it down.
They push it down. But again, I felt it's a really good system just to get people in a really easy way to understand what they are buying and how much healthy it is.
To have ability to choose.
Yeah.
Again, moving from to another on to another wave of questions about pregnancy and mothers and postpartum and a lot of the interesting topics that you work on. As we were saying in the beginning of the episode, the first episode of this season, we had it with Natasha Heath, that is a postpartum educator, and she's an amazing mother and a woman and a lot of other things, as you are. And and we talked a lot with her about, what are the needs of women during pregnancy and also in the postpartum period. But we mainly focused on the mental needs and then how design can help in those areas. So with you, we wanted to mainly focus on maybe the physical part of the health. So what are the physical needs and how can design, urban design, architectural design help in creating like healthier environments, both during the pregnancy and in the postpartum period for women in, let's say, again, whenever I use these words, I put it in quotation marks, in developing and in the developed world. So how can those look different? And
I think obviously there are different issues in different contexts. I mean, there are two that kind of comes to mind that are quite big. One is, from a very clinical perspective, you want to make sure woman has access to the clinical care she needs. Mm-hmm. And that's throughout pregnancy, during birth, and postpartum. Now, in a context like Italy or the UK, most of the time you have a relatively good physical access to the hospital or to smaller clinics, like a referral system. In many low-income countries, that's not the case. Mm-hmm. So you're asking women to come to the facility. Some of them take like 3-4 days to walk to a healthcare environment. So if you're saying, I mean, now the new WHO guidelines are like 8 antenatal care visits. I mean, if you're asking a woman with other children at home to leave for multiple days to access a facility whilst pregnant, probably if it's a low-income country, it could have some extreme weather conditions like extreme heat. That's not ideal, right? So you need to think from a built environment point of view, how do I make that as easy as possible? As Mohammed goes to the mountain, on the mountain goes to Mohammed. And that's kind of something that every healthcare system has to decide and needs to figure out. Obviously, the bigger the facility, the wider the spectrum of clinical care they provide. Mm-hmm. So in that sense, over the last 30 years, there was a huge move towards, instead of going for a smaller clinic with less skilled staff, bigger hospitals with a wider range, wider spectrum of care being provided, and usually higher level care. Mm-hmm. The problem is that you have less of these. Yeah. In many low-income countries, you don't have ambulance systems. You can't just call and say, can you take me to a hospital? It's not an option. And the same goes to birth. You can't plan when you're giving birth. It's one of the things you really can't plan. That's why the maternity runs like a A&E, like a emergency unit, because it's 24/7. Yeah. Maybe in 1,000 years we plan when we deliver, but not now. So at the moment we're still dealing with a service that needs to run 24/7. Mm-hmm. And it's already, I mean, even from the point of view of someone who delivered in amazing healthcare environment, there is still a bit of anxiety. How do I get there? I have to change environment and so on. Can you imagine someone who's like 3 days walk away? So actually in this behalf, there has been amazing work, for example, done around the women's groups. They've been tested in several countries around coming together during pregnancy to understand what they need during pregnancy to facilitate access to the healthcare environment. Mm-hmm. So the community comes together, for example, to build a stretcher, to collect money, to call a taxi, but it's very bottom up type of solution. But a lot of this is just infrastructure. Mm-hmm. So you need roads, you need ambulances, you need a good referral system. And some of these things are very basic. There are some some things have been tried out with regards to maternity waiting homes. So in places where access is very difficult, you have places where women come a few days before they're due to deliver. Again, it doesn't super work well because, again, it's very unpredictable when you're going to deliver. But it works in some cases. So you can plan to have these maternity waiting homes, women come. Again, not super easy to do. For example, I worked in maternity waiting homes in South Sudan. That was a very remote context where women really had to walk a long time before getting to the facility. And there was also a cultural issue, right? So you're putting together different tribes in the same maternity waiting home that usually don't particularly get along. So that has huge barriers to be discussed. So what do you do? Do you do 3 maternity waiting homes? Do you have the resources to do it? How do you deal with it? So not super easy. But the same goes for, access is not necessarily just an issue in low-income settings. I think it goes for some high-income settings too. So, for example, if you think that, for example, especially postpartum, I think when you have such a small baby, you're still recuperating physically from the birth. Some systems where the midwife come to your home are much better for your physical and mental health than you having to be expected to go to the facility. And so from that point of view, I think thinking about the built environment, you can organize your postpartum services very differently if you can afford to do that, if you can afford to do home visits. And there are even in Italy, even in the UK, there are still some maternal health centers that are not located in the right way. And they don't allow access to most women that are in the catchment population. So even just like geographical decision making about where a center goes should be really well thought through. Yeah. Does that answer a little bit of your
Definitely
of your question? Yeah.
it does. No, in my brain I'm just thinking about because I remember but probably this won't work for giving birth. But I remember there was the example in Rwanda where the pharmacies were there are these mobile pharmacies that they move with drones, and I was in my brain I was imagining if something similar could work.
Well, it's interesting. In Canada, they have this system where actually the, from how do they call them? For the more indigenous communities, essentially, they can access helicopter services because they don't have that's quite extreme and has to be really well funded. But you have those situations. I knew a midwife that was literally going to these very remote places, and if there were complications, they would arrange a helicopter to a bigger health facility. But again, I think the discussion we had so far is much more to do with making sure mother and baby are alive. There's a whole other part of pregnancy and postpartum, which is equally important. Well, depending of your values and belief system. But I think it's also really important that you think about pregnancy as a very, very natural process. About half of the pregnancy, or at least a third of the pregnancy, will be uncomplicated. It'll be a very smooth process. And I think you also need to cater for that. And making sure the built environment around healthy pregnancies have a chance to be in an environment that is as comfortable as possible. Making sure that you feel comfortable when you're giving birth or when you're in antenatal care or postpartum care means that your hormones are in the right place, means that your fear is not blocking any normal physiological processes. And it's a very tricky one, right? Because, we're using public money to do this. So you have to think about making sure people are alive, which costs a lot of money because you have to get access to people. You also have to make sure people are happy in a friendly environment. And getting this right is really hard. I think the best models that I've seen so far is when the clinical department is very close to a sort of what some people call natural birth or midwife-led unit. So at admission, you're essentially departed. If you have complications, you go to the more clinical ward. If you don't have any complications, you're not a high-risk pregnancy, you go to the midwife-led ward, which is much more home-like, you have a double bed you can share with your partner. It's decorated in a certain way. You don't have as many machines around. Even from the point of view of the, some LA person who doesn't know anything about clinical practice, you kind of feel in a more sort of home-like environment. I think it's important that you provide both to people, even though it is more expensive, right? Because you have to cater for both priorities. Safe and I don't know how to call it. Sort of comfortable and making sure that you can have a natural birth in the best possible way.
And I feel there are so many places that, beside the hospital, that could be more, I don't know, more open, in the sense that when I was a long time ago, I was researching hospital and how basically hospital can influence your health, but even as you're saying, your level anxiety. There are so many things that, you don't know what it is, but you enter a hospital, you're already freaking out because you don't know where to go. You don't understand the wayfinding. Maybe you don't even find someone to ask to for direction. And it's a bit of that. So a bit of how do you make sure that people is comfortable and comes to a place where it's calm. And the other is, there's a hospital I like now. It's better than others, but I won't say the name. And but what's good of this hospital that you arrive basically in a place that is almost a public space. So it's almost have a square, we could call it like this. You have people waiting in a huge waiting room, but that is close to a small supermarket, a bar. So you don't feel that you enter a place where, people is just going to put you in a, I don't know why we feel that healthcare, should be white and ugly and cold. I think it could be done in a different way. So even thinking about opening up in a different way, these places could be really important. But you don't even need to go to hospital. Even libraries, like libraries where you just shush people for studying, don't make any more sense. So it's even libraries are trying to understand how to be different, how to become a place where community go when people meet, because we need spaces to meet at the end of the day. And if the place where you meet, you can also take care of your health, it's bingo. And also how much green can affect that, but that's another chapter.
Absolutely.
That's another huge chapter where you are in the hospital and you look just at gray spaces and gray wall.
And I think there has been huge strides in the last 30 years on this, honestly. If you think of how our moms gave birth and how, the babies were taken and put in another room, there has been huge improvements. There's still lots to do, but I think we're going in the right direction. And I think there are some, unfortunately, financial reasons, logistic reasons why some of these environments have to be really close together.
Of course.
Like if something goes wrong in a midwife-led unit, you have to be able, in a split of a second, to be transferred. Because there are some things that can happen that you can't predict, unfortunately, with any epidemiological models, and you have to have that clinical access care. Well, it's not that you need. In order to make sure you have the highest chance of survival and that's the best for you. Of course, if you want to risk it, it's up to you. It's not a problem. I think also it's lovely to have a home birth and everything, but it's just for you to be able to decide on what probability you want to risk these things, even though they're very, very infrequent. So I think there are some reasons why some of these things need to be logistically linked, but they can have completely different outlets in terms of how they look, how they're presented. as you say, how you enter, what type of environment you find. And I think that's very important. And there are some things that have really improved. Like if you think now we can have a partner during birth,
Yep.
right? Which, most of the time it wouldn't happen 30, 40 years ago, which is crazy. Still now in the UK, you can have a partner even during a C-section in a surgical theater. In many other countries, you can't. So I think a lot of the barriers that exist are still cultural rather than real. There is no clinical reason why you couldn't bring your partner in your C-section, but yet some places don't allow it. So I think some barriers are just cultural, normative that we have to go through. But I think it's going in the right direction with regards to maternity services. Hopefully it's gonna keep going this way. Hopefully the political environment will allow this to. And I think the other thing that it's really sad, unfortunately, is there are lots of U-turns around abortions, and that's something usually you don't discuss in maternal health, but it's quintessential,
Yes, it
like
is.
100%, one of the fundamentals. Making sure the abortion rights are protected is one of the things that make us want to be mothers and allow us to be good mothers. So I think we need to make sure that the thinking about design also touches that topic. I know we don't, it wasn't the focus of today, but sometimes often people don't think about it when they think about maternal health, but it's so fundamental. And unfortunately, many political environments at the moment are doing some U-turns on this topic, which is really scary, personally.
And especially don't feel judged. But even when you are pregnant, I mean, sometimes you feel judged by the actual doctor that is, is taking care of you, and in abortion is even more important. And the way they are asking, this question that they have to ask every time, like when was your last period, did you had abortion, and it's like you're just asking me this like this, as you
Very
don't know
personal
what's
questions.
you don't know what was my experience, what was the person's experience, what
like
was
tick, just-
just like I've done it. This is I just need to put a number, and and it's, I don't know how you flip that.
But that, you see that very different in different countries.
Oh yeah, of course.
Honestly.
I'm talking about the
Yeah, you
Italian
do. Like
one.
I think the experience in Italy, not everywhere, definitely not everywhere, but the doctor culture is still like top down, and I think that has changed a lot in many other places. That you're almost like, it's a bit like talking to the priest. In Italy, it's like a little, it's closer to God than you are, sort of like. So this is, but it's not quite like that, right? So I think it's changing a little bit, and it's becoming more accessible. Hopefully the younger generations will be able to flip that around a bit more in terms of culture, of making a bit like we said earlier at the beginning, like language, how you speak to people. I'm an epidemiologist. I hang out a lot with doctors, and still sometimes I'm like, okay, but you have to explain me this,
What do you
better,
mean?
because that doesn't mean anything to me. You have to go step by step. What does it mean? What consequences does it have? What is the probability of this? What does it mean for my daily life? And again, but it's also to do with training. If you think about the curriculum of most clinical practice training or doctor training, they don't have anything to do with, or very little to do with, how you speak to people. Is that a different role? Could be a different role for people. Like maybe it's not something doctors should do, maybe it's something else. And sometimes we ask a lot of these people, right? Because they have to be, they have to be on top of things around clinical practice, but they also have to be really good people persons. And as we know, we're all better or worse at these things. So I think if we want them to be better, we also have to make sure their training curricula kind of reflects that,
Yeah, I want too much from people, because I'm expect even architect to be able to talk to people. I don't know. There is a basic, I think need.
For every profession is needed to be.
Yeah, but even if you think high school,
Yeah.
do we get these like soft skills in high school? No.
Yeah, no, we don't. Absolutely.
It's not. In a way, it's becoming better people, right? Being able to communicate, and it's not something that they teach us. Some jobs have it more than others, but essentially it's something that is up to us to develop as human beings.
Yeah.
in a society where not necessarily this is rewarded. So yeah, I think it would be good to rethink education in that sense.
Absolutely.
Yeah.
We'll get there. Don't worry.
So many
I'm
things
working
to
on
work
it.
on. Yeah. Good. Yeah. Can I ask one
Yes,
more
of
question?
course.
I mean, to go in it, like answer me as short as you want, because also we don't have so much time. But yeah, I mean, if you right now, like, they would ask you, how should we go with the healthcare facilities, and like how many healthcare facilities should exist, and the density of it, and the roads and infrastructure and all of this, let's say in the more low income countries, what would be the better solution for you? Like, and I think you touched on that. You said it's better to have more central facilities, and then a good infrastructure that connects to that. But I think then moving towards this direction would move us towards the same development models that we had in the West, and then that created a lot of extra problems, both in terms of climate change and how we act towards the land, but also our physical and mental health, because we became more concentric and all of that. So what would you think, like, because there is less density and less development in the sense that is like defined in the West in terms of infrastructure and those kind of things. So what would be a like in between good way that we try to respect these different fronts, but also give access to healthcare?
Yeah, I don't think there is one size fits all model, and I think countries need to have an understanding of what they can achieve given their resources and cultural milieu and their priorities. Certainly, one thing I can tell you, no matter where you are, in remote places, it's really hard to keep skilled professionals. So if someone is skilled, they go away. They go towards the urban centers. And that's just human nature. So you have to face that. And that's one of the biggest challenges in low resource settings, that you have a brain drain from the rural areas to the urban areas. But I mean, is anyone of us living in their hometown at the moment? Yeah, exactly. So we're all kind of, I mean, our species is amazing at migration. We love going to places, discovering, getting better, and there is nothing we can do about that. But we have to face human nature and think, what is the next best possible thing I can do to mitigate that, given the resources we have? Because of course, if we had all of the money in the world, you can just pay someone 10 times more, and maybe they would stay in rural settings, but that's not a possibility. So I think the biggest challenge we have in maternal health in rural situations is this one. So I don't know what's the next best. I mean, Canada has helicopters, but
Yeah.
can you really do that in context? Exactly, I don't know. I mean, the answer is probably not. But I think as we said before, I think it's really important to consult people. And I mean, the other thing is that there is nothing that stays the same, right? Like, so, rural situations change. So maybe one village doesn't exist in 50 years, or maybe actually get like an influx of population for whatever reason. So I think the main thing for me is not stick to old or existing models just because that's the status quo. You can never just sit down on where your plans were or are. I mean, in building cycles of rethinking whether something worked and how the demographic has changed and what the needs have changed is fundamental in any policy prioritization. So I think that's the main thing to me. It's not necessarily like shifting to one model. It's thinking, how do I build in flexibility in my strategy?
I love that. Okay. Perfect way.
I hope I answered a little bit.
Yeah.
Okay, to finish.
Yeah. Really well.
Oh, thank you. It's been really, really fun to and
Yeah.
really nice to talk to you. So thanks so much for the invitation. It's
Thank
been a
you.
pleasure.
Great conversation.
It's really nice that you're doing this.
We have so many things to do now.
And we are gonna email you.
Yeah. Thank you very much, Georgia. We'll
Thank you. Have a
talk
lovely
soon.
day, and
I think.
yeah, hello to everybody who's listening.
Yes. Thanks
Bye.
again.